Okay, I think we can start the meeting now. So in the previous, two sessions, first we discussed the presentation of a case with breast cancer. We discussed how a patient is evaluated, the history, examination, briefly touched upon the risk factors. Then in the last week we discussed the details of the local regional treatment. The surgical management was discussed in the first meeting, and then the last time we discussed uh, radiotherapy, local regional radiotherapy discussed, and today we will discuss the systemic therapy of breast cancer. So, I mean, it's a vast topic, uh, but I think we will cover all today. So, please start.
Good morning, sir. Can you make me the host? I have to share my screen.
Okay, one sec. Sorry, who's that? Who was that asking?
Sir Janil.
Janil. Okay, make host. Yeah, now you are the host. Yeah, you are the host now, Janil.
Okay, sir. Is my screen visible?
No.
Is my screen visible now?
No, one sec. At least I don't see your screen. Can anyone else say if they can see his screen? Can anyone else see his screen? I can't see his screen.
No, sir, screen is not visible.
Hmm.
So there's some error coming that I'm able to share my screen.
Oh dear. If you anyone else has your presentation,
Sir, yeah, Ankush can share this.
yeah, where is Ankush? I'll make him the host. Yeah. Yeah, so he was able to share the screen, but you couldn't, so I don't know. So you start from the okay. Sure, please start.
Good morning, everyone. Myself, Janil Doshi, and I'll be presenting on systemic therapy in early breast cancer. So we'll be looking at chemotherapy, followed by targeted therapy, and then followed by the hormonal therapy. Next screen, please. So chemotherapy for early breast cancer. Why chemotherapy? Because breast cancer is responsive to a whole cohort of cytotoxic agents, mainly anthracyclines, taxanes, cyclophosphomides, platinum, methotrexate, 5-fluorouracil, oral capecitabine. So choice of the regimen depends upon the oncological outcomes and the toxicity profile. So this is a meta-analysis by EBCTCG group, where they have analyzed randomized trials, including various chemotherapy regimens like CMFs, CAF. So the 6 months of anthracycline-based polychemotherapy reduces the annual breast cancer death by around 38% in women diagnosed less than 50 years and 20% in women diagnosed in age 50 to 69 years. So irrespective of use of hormonal therapy, nodal status or other tumor characteristics, such regimens were significantly more effective than the CMF chemotherapy. However, anthracycline-free regimens comprising carboplatin, taxanes have been tested in phase 2, but reporting similar outcomes to anthracycline-containing regimens and improved cardiac safety. However, there are no yet standard of care and is considered in low-risk patients with having cardiac comorbidities. So historically, the classification of early breast cancer encompasses a cohort of patients which were even T2, T1 with having no mobile axillary nodes, or N1 or T3. So division was based on the feasibility of upfront surgery. However, the advanced understanding of disease biology and benefits of upfront systemic therapy, a subset of patients of early breast cancer are being administered systemic therapy in the neoadjuvant setting, often to downstream the tumor and facilitates breast conservation surgery in patients otherwise requiring upfront MRM. So the NACBP 18 and NACBP showed that there is no DFS and OS difference between the groups treated with either adjuvant or neoadjuvant systemic therapy. While in cases with large tumors to breast ratio, chemotherapy in the neoadjuvant setting can potentially improve the chances of breast conservation and cosmesis. And also the PCR after neoadjuvant chemotherapy is overall a good prognostic indicator. So what are the factors which guides the decision of chemotherapy? One is the patient related, which includes age, the comorbidity status of the patient, performance status, patient's preference, and risk benefit discussion. And of course,
So Janil, before you go into all this, there are a few names in chemotherapy, adjuvant chemotherapy. Would you remember any of the names or the philosophy which sort of decided that you should use adjuvant chemotherapy?
sir, earlier the breast cancer itself is considered as a systemic disease.
Yes. So earlier Halsted said everything is local and regional, the various modes of Halstedian era. So who said that breast cancer is a systemic disease and you need a systemic therapy? There's a name? No? See, I mean, it's not possible to remember all the names, but few names. So Fisher, that was his paradigm. Okay?
Okay,
So all the NSA-BP trial, A stands for adjuvant, National Surgical Adjuvant. So in addition to surgery, whatever adjuvant therapy. So Halsted believed that you just do surgery, more surgery, and you will cure. And then Fisher, although he was a surgeon, he thought that along with surgery, you need adjuvant therapy also because some cancers have a systemic nature. And for that, surgery, of course, with surgery, you can't remove that. So that you have to know. And the name of Veronese from Italy. Okay. So, okay, carry on.
And the tumor related factors mainly is the tumor size, HER2 status, the lymph node status, hormone receptor status, grade of tumor, and the genomic expression. So this is a Oncotype DX report, which included 21 gene assay, which was done on the fresh frozen sample emitted blocks. And this was incorporated in the prognostic staging of breast cancer in the 8th AGCC edition, mainly for T1, T2, and 0, but which included the ER positive cancers. And this was validated in the NSCBP 14 adjuvant tamoxifen trial, which we seeing in the subsequent slides. And it categorizes the patient into low risk, intermediate risk, and high risk. So broadly, the systemic therapy in breast cancer. Why do we need systemic therapy for adjuvant treatment? It increases the risk of recurrence. It improves the overall survival. While in case of neoadjuvant setting, it converts the locally advanced, the inoperable to operable tumors. It can be even early breast cancer, and it facilitates breast conservation. while for palliative, it relieves symptoms, improves the quality of life, and prolongs the survival. So we have seen this already in the previous slide. These are the tumor characteristics and the patient characteristics. Next slide, please. So the prognostic factors and the predictive factors. The prognostic factors are tumor size, tumor grade, and the lymph node status, while the predictive factors on which therapies depends is mainly the expression of the hormonal receptors and the HER2 gene amplification. So this is a classification by Sain Gallin, which includes mainly the 4 types of the molecular based on the gene expression, that is luminal A, luminal B-like with HER2 positive, and HER2 positive non-luminal, and the last one is the triple negative. So in luminal A, it is mainly ER/PR positive, HER2 negative. So for such patients, we mainly recommend the endocrine therapy. However, systemic therapy is administered if there is high gene recurrence score with oncotype DX, that recurrence score is more than 25, there is grade 3 disease, extensive LVSI, more than 4 lymph node metastases, and young age patient. While in luminal B, which is ER positive, PR low positive or negative, and HER2 negative, and Ki67 is between 20 to 29. So for such patients, we offer endocrine therapy as it is hormone receptor positive and cytotoxic for most of the patient. In HER2 positive, luminal B like, which is ER positive, HER2 expression or amplification is there, then we need to administer systemic therapy and anti-HER2 therapy, which we'll be seeing in the subsequent slides, and the endocrine therapy. Next slide, please. So this is the goal of adjuvant systemic therapy is to prevent the recurrence of breast cancer by eradicating occult micrometastatic deposits of tumor present at the time of diagnosis. So if systemic therapy can control microscopic tumor dissemination, then loco-regional therapies to treat clinically apparent or high-risk areas may be effective, achieving a multimodal cure. So this is a table which is showing based on the HER2 status and the hormone receptor status. So if the hormone receptor status is positive, we give endocrine therapy. And based on the HER2 status, if it is negative or normal, then we decide on the systemic therapy, as we saw in the luminal type A, if there is any high-risk features. If hormone receptor status is negative and even HER2 is negative, then we need to give systemic therapy. If it is positive, then we need endocrine therapy plus chemo. And if the HER2 is positive and there is hormonal receptor is negative, then we need to give chemo plus anti-HER2 antibodies. So we'll be looking at the various trials, which is showing that whether polychemotherapy versus no adjuvant therapy, anthracycline versus no anthracyclines, lower versus higher dose of anthracyclines, and taxane versus no taxanes. So you can go to the next slide. So these are the various trials which have shown how the chemotherapy regimen has evolved. So first by Bernardon et al. In 1976, he has compared surgery alone versus 12 cycles of CMF, and we can see on 20-year follow-up, there is a significant improvement in the disease-free survival and the overall survival. Similarly, NSABP, NSAB19 has compared surgery alone versus methotrexate followed by 5-fluorouracil, which has shown the increase in the DFS. So these are the various trials which showing how the chemotherapy regimen has evolved. So the main one that we see is the Calgb 9344, which is showing in which the control arm is adriamycin cyclophosphamide, and the treatment arm is followed by the taxanes, which show there is improvement in the disease-free survival and the overall survival. So this is the evolution, that 6 cycles of CMF, 6 versus 12 cycles. Then came the adriamycin-based regimen or the epirubicin-based regimen, followed by the 4 cycles AC, which is the currently standard of care that we practice, and then followed by the sequential addition of taxanes, in which we'll be seeing the dose dense schedule of taxanes is a weekly and 2 weekly.
Sorry, you said 4AC is the standard of care only in some patients, okay?
Yes, sir.
Okay, so don't say 4AC is the standard of care for all cases.
So this is a EBCTC meta-analysis, which is showing firstly the CMF, which was practiced initially versus no chemo. which showed there is absolute gain of 10.2% improvement in the risk of recurrence, the breast cancer mortality, and also the overall mortality. Second one is comparing the anthracycline versus no chemotherapy, which also showed there is absolute gain of 8%, 6.5%, and 5% in case of recurrence, breast cancer mortality, and overall mortality. However, the standard dose of anthracyclines versus the CMF has shown no improvement in risk recurrence cancer mortality. It has shown when the anthracycline cumulative doses were higher than 240 milligrams as compared to that of CMF. So there was absolute gain of 2.6%, 4.1%, and 3.9%. So 4 AC was equal to 6 CMF, and the dose of anthracycline which is used was mainly doxorubicin. The dose is 40 to 60 milligrams per meter square. Epirubicin is preferred in patients having cardiac comorbidities, which is 70 to 90 milligrams per meter square. So the magnitude of benefit was similar across all subgroups. So this is a meta-analysis by, again, the EBCTCG, which is comparing of addition of taxanes. So in this trials where the same control regimen were used, like 4 cycles of AC followed by taxane versus just 4 cycles of AC. So we can see there is absolute gain of 4.6% in RFS, 2.8% in breast cancer specific overall survival, and also there is a reduction in the overall mortality. While when they increased the number of cycles of taxane, they similarly added cycles of AC. So they have added 4 cycles of AC, and then they have compared with addition of 4 more cycles of taxanes. So, however, the risk of recurrence and the reduction was not that significant by adding additional cycles of taxanes. So this affirms the benefit of taxanes when added into adjuvant setting. So benefits were seen independent of age, the nodal tumor status, tumor grade, and the ERPR status. So the question is whether we should go for concurrent versus sequential anthracyclines and taxanes as adjuvant chemotherapy for early breast cancer. So this is a meta-analysis by Shao et al. In this first picture, we can see the meta-analysis of the primary DFS. So it was shown that sequential chemotherapy was beneficial rather than concurrent. And also in the overall survival, sequential. So we have various studies which we're looking in the subsequent slides about the secondary outcome was the overall survival. So this is just to show the what is the sequence that we follow. Either is 3 weekly or once weekly. So in 3 weekly, the dose per cycle is 175. That is more as compared to the weekly cycle, but the total dose is 700. While in case of weekly cycle, it is 960. Similarly, in case of the second one is of docetaxel, which is 100 if it is giving 3 weekly. So total dose is 400. While if it's giving once weekly, the dose per cycle is 35. The cumulative dose is 420. So this is a trial which is showing that we have understood that the taxanes help in the adjuvant setting. So what should be the regimen that we follow? Should it be 3 weekly or once weekly? So here we can see that they have compared weekly docetaxel, 3 weekly docetaxel, weekly paclitaxel, and 3 weekly paclitaxel. So in the first graph, we can see that the disease-free survival was better in case of weekly paclitaxel. But in case of docetaxel, it was every 3 weekly. So when we see the hazard ratio, so weekly paclitaxel was preferred, and in docetaxel it was 3 weekly which was preferred, and also similarly in case of overall survival. So this is the toxicity profile comparing of paclitaxel and docetaxel. So grade 3 or grade 3 neuropathy was more in case of weekly paclitaxel, while the other toxicity profile was comparatively lesser, like neutropenia, febrile neutropenia, infections. However, grade 4 neuropathy was more in case of weekly paclitaxel. Now the question arises whether should we go for dose-dense chemotherapy or versus conventional chemotherapy for early breast cancer. This was a systematic review by Dover et al., in which it was shown that dose-dense regimen was better, which increases the disease-free survival and also the overall survival. So this was a pooled analysis by Shapiro et al. In this, they have compared 4 cycles of AC, which we routinely practice, versus that of taxane, in which they have used docetaxel and cyclophosphamide. So it was shown that cyclophosphamide with taxane, that is docetaxel, was associated with significant improvement of DFS. TC was also associated with significant improvement of overall survival. So TC was superior irrespective of age, hormone status, HER2 status, or treatment. But there was another trial by ECOG, which showed that there is. Can you go to the previous slide? So in this, it was shown that the TC was associated with significant improvement. But in this, what they have given is higher dose of docetaxel as compared to that of routinely practiced. And also, most of the patients were high risk, all were node positive. So in the subsequent trial by ECOG, it was proved that 4AC is still the better than case of TC.
Better. When you said 4AC is better than.
No, sir, as good as, sorry, sir. It was not inferior to that of TC, which was seen by the Shapiro et al. Paper. So this we have already discussed that luminal A-like, so it will be endocrine therapy in majority of the cases, only to consider chemotherapy if high risk features are present. Luminal B-like, to add endocrine therapy plus chemotherapy for majority of the cases. And if it is HER2 positive, and so we need to add chemotherapy plus anti-HER2 treatment, which we'll be talking subsequently. And if it is HER2, and if triple negative, then we need to administer systemic therapy. So this paper shows the.
Oh, you go on to this, other aspects. So one is the benefit in terms of disease-free and overall survival. Other is the toxicity. So what decides the magnitude of benefit?
Sir, in case of early stage cancer, it mainly depends upon the risk factors. Like if there is high risk factors, in case of.
We're talking of all breast cancer. So all, when you're talking of adjuvant therapy, so what is the risk, baseline risk of recurrence without giving adjuvant therapy, adjuvant systemic therapy? So that is one thing. And what governs the risk of toxicity? The proportion, what percentage of patients will develop toxicity and the grade of toxicity?
Yes, so mainly the regimen that we use is 4 cycle of.
So the drugs that we use.
So adriamycin and cyclophosphamide.
So the drug that is used, the total dose, the dose intensity or dose density. So this is the treatment, and then patient. Okay. So it's a fine balance. So that is how the whole thing is balanced out. What is the risk of recurrence? So you give additional toxicity or risk subject to additional toxicity only if you know there will be extra benefit. Okay. So like you see in low risk disease, node negative disease, it's not worth giving them the toxicity of taxanes or dose dense. Similarly, dose dense regimens, you did not compare the toxicity between dose dense and other regimens. So whenever you're giving, increasing the risk of toxicity, there should be an additional benefit. That is the whole premise of using various regimens for various stages of disease and patient characteristics. Okay.
Yes. So this is showing about the long-term clinical benefit in case of patients treated with neoadjuvant chemotherapy. So the patients who attained a pathological complete response, which is defined as YPT0, was having longer event-free survival and also overall survival than patient with residual cancer. Also, PCR subsequently improved outcome in case of triple negative breast cancers and HER2 positive patients. This we have already discussed. Next slide, please. So while in case of triple negative breast cancers, there is no targeted therapy options like HER2 positive or ERPR positive. So the overall prognosis is poor. So mainly relapse pattern that we see is mainly in the short disease-free interval. There is increase in visceral mets and also even seen as metastasis is common. So in case of chemotherapy in TNBC, when to start, which regimens we use, and also what is the benefit of neoadjuvant approach. So this is comparing that longer time to initiation of adjuvant chemotherapy in patients with TNBC we have worse overall survival and also worse breast cancer specific survival. So in this, we can see the distant recurrence free survival based on the how long after the adjuvant treatment was started. So if it was less than 30, 31 to 60, 61 to 90, and more than 90. So the maximum benefit, the recurrence-free survival was highest in case of when the treatment was started within 30 days as compared to that of more than 91 days. So the table is showing about the disease-free survival at 5 years. You can see it is 85.7 when it drastically drops to 68% when the adjuvant treatment is delayed. So this is a paper by the CalGB trial which showing the addition of taxanes, which we already discussed earlier. So it was more beneficial where it was added in case of HER2 positive patients. So when we can see the C and the D graph, that the disease-free survival was better when HER2 positive, or the patients were HER2 positive, irrespective of the estrogen receptor status. Also, similarly, irrespective of the ER status, the HER2 negative patients which were HER2 negative showed better disease survival in with use of weekly paclitaxel. Next slide, please. Next slide. So this is regarding the role of capecitabine. So this is a CreateX trial by Masood et al. In which 910 patients were there. And the capecitabine dose was given was 2500 milligrams per meter square per oral. So no, in these patients after giving neoadjuvant therapy, after surgery was performed, if there is no complete response on pathological assessment or a complete regression with positive lymph node, then were randomized to either capecitabine group or the control group, which was a standard therapy. In case of next slide, please. So this showed that the adjuvant capecitabine was safe and effective in prolonging the disease-free survival and overall survival among patients with HER2 negative breast cancer who had residual invasive disease on pathological testing. Next slide, please. So now looking into the individual drugs. So mainly we use these anthracyclines. So the mainly side effects of anthracycline is cardiotoxicity, which is
Hello. So, do we use maintenance or adjuvant capecitabine for all patients with breast cancer, or in a subset of breast cancer patients who may benefit?
So only in subset of breast cancer patients who are triple negatives, we have no any to offer them any maintenance therapy like trastuzumab or any hormonal therapy. So now in such patients, we give off 6 months of capecitabine for maintenance.
You had not mentioned that. Okay.
So mainly the cardiotoxicity, which is cumulative at high bolus doses. Acutely, there can be arrhythmias, or chronic, there can be heart failure and cardiomyopathy. So this becomes important when we are adding also trastuzumab in HER2 patients, because even trastuzumab is known to got cardiotoxicity. So increased risk with prior history of cardiovascular disease, prior anthracycline-based therapy, concurrent cytotoxic drugs like trastuzumab, or history of chest irradiation, extreme of ages. Also causes myelosuppression, mucositis, and alopecia, and slight risk of secondary malignancy and extravasation.
And what is the difference between cardiotoxicity seen in anthracycline versus trastuzumab, which
So,
is reversible? So, cardiotoxicity between anthracycline and trastuzumab. Is it the same or is it different?
sir, mainly because of trastuzumab, we see mainly the cardiomyopathies. While in case of anthracyclines, it is heart failure. So, sir, anthracycline-based toxicity can be reversible and can be managed.
What? What? Anyway, I don't think we have time to discuss that, but please, see what you have said and, go back and read, please. Okay. And others also. Okay. What he has said, you don't take his word. Okay. Carry on.
Looking at taxane, mainly this myelosuppression, there is more thrombocytopenia. Mucositis, there is hypersensitivity reactions. The peripheral sensory neuropathy that we saw in that table comparing 3 weekly versus once weekly. Fluid retention, which is seen in docetaxel or weekly paclitaxel, and also full body alopecias.
So, what is the side effect of or toxicity of taxanes, which you don't see with other drugs used in breast cancer management? What is specifically attributed to taxanes?
Sir, mainly
Patients who are on taxanes tend to develop that side effects and distressing side effect. See, you can't just list out toxicities without knowing what is relevant. When a patient is on multi-agent, multi-drug regimens, you have to know which drug is causing this toxicity, and others may be contributing to it. So, neuropathy, it is mainly because of taxanes, okay? As well as hypersensitivity reaction is of all the other regimens used or drugs used, it is mainly because of taxanes.
okay.
Okay, carry on.
Cyclophosphamide, which causes hemorrhagic cystitis, also causes SIADH at higher doses, myelosuppression, and there's a risk of secondary malignancy like AML.
In the doses that we use in breast cancer regimens, these are not really an issue except for myelosuppression. It contributes to the other drugs that are used. Next.
Yes. This is the overall summary that we saw already and discussed.
So tell me, what are the main risk factors for predicting systemic spread of breast cancer? Spell it out. Don't just say the stage of disease. So what in the stage of disease?
Sir, the nodal stage.
So one is the nodal stage. That is very important. Then
The second is the HER2 positive or the estrogen receptor positive.
okay, so the time whether it is HER2 amplified or a triple negative, that governs. Then the tumor stage also is important. A locally advanced breast cancer versus just a very small T1 tumor.
Yes, sir. High histological grade.
Yeah.
And also, sir, lymphovascular invasion.
Oh, that's correct. And age itself, in younger women, the cancers tend to be more aggressive. But it is also a reflection, they tend to have more high grade and triple negative breast cancer. So these are the risk factors. So you have to see, when all the trials you have seen, different trials have had different inclusion criteria. So when you extrapolate the results to your practice, don't just say in breast cancer or early breast cancer. Within early breast cancer also, some may have only node negative or T1 or small T2s. Others may include even T2 and T3s. So you remember what was your patient population from where these was used, and you have not mentioned about the need for growth factors or this thing for dose. Why is dose dense regimen not routinely used for everyone?
So we need to give growth factor. Filgrastim support is required. There's more chances
Yeah,
of
so that is important because
neutropenia.
toxic and patients can die. We did not talk about mortality because of this, but if in the trial setting patients are supported very well, if it is not done in practice setting, someone could die because of adjuvant chemotherapy. You just wanted to add that extra 3% survival benefit, but if 5 out of 100 women die because of the toxicity which was not managed, then you sort of end up losing. Carry on.
Now we're looking into targeted therapy. So this is timeline for the evolution of the targeted therapy, starting with anti-HER2 antibodies, that is trastuzumab, followed by the TKIs, the mTOR inhibitors. Next slide, please. So targeted therapy mainly for HER2 positive patients is the trastuzumab, pertuzumab. Also, we have antibody drug conjugates like trastuzumab, amentensin, and also tyrokinase inhibitors like lapatinib. So this is the ESMO guideline showing the overall management of the HER2 positive early breast cancer. So while in case of T1N0, so patient undergo upfront surgery and locorenal RTF indicated. So if it is PT1 and there is node negative, then we just give 12 cycles of paclitaxel and maintenance cycle of trastuzumab. If it is node positive, then we need to give 6 to 8 cycles of chemotherapy with trastuzumab, pertuzumab, and then followed by again 1 year of maintenance, and accordingly to add hormone therapy based on the estrogen progesterone receptor status. While in case of T2 or node positive, it is 6 to 8 cycles of chemotherapy plus trastuzumab plus pertuzumab. And then according after surgery and local RT if indicated, if still there is residual invasive disease, then we give 14 cycles of TDM1. And if there is a pathological complete response and it was CN0 at initial diagnosis, then we just complete 1 year of maintenance trastuzumab and add a hormonal therapy as indicated. And if it was node positive or PN post surgery, then we need to complete 1 year of trastuzumab, pertuzumab, and to add hormone therapy accordingly. So trastuzumab is a humanized IgG1 which targets the domain 5 of the HER2 receptors. It's given in a HER2 overexpressing breast cancers. The standard duration is 1 year for both neoadjuvant as well as adjuvant settings. HERA trial, which reported there is no additional benefit from adding 1 more year of maintenance trastuzumab. Addition to chemotherapy in HER2 positive early breast cancer, it significantly improves the overall survival by approximately 30%. But if the patient is HER2 positive 1 or 2 plus without gene amplification, then it is of no benefit. So mainly side effect is of cardiomyopathy. So it requires regular cardiac monitoring before starting and as well as during treatment. And also as if we have used anthracyclines, then we need to regularly monitor the cardiac function. So it is recommended to withhold for more than 60% absolute decrease in the ejection fraction from the pre-treatment values. So these are the two main trials which have compared adding trastuzumab as the maintenance therapy. So in first, the DCRG006 trial, so we all were HER2 positive high risk early breast cancer. So in this, they have compared doxorubicin plus cyclophosphamide and compared to that of doxorubicin and docetaxel plus trastuzumab in the experimental arm, while there was no trastuzumab in case of control arm. Similarly, there was one more regimen, that is TCH plus adjuvant chemotherapy plus 1 year trastuzumab plus no trastuzumab. So here we can see that the disease-free rate was statistically significant. It was 74.6, while it was 67.9 in the control arm. Similarly, as we discussed that in the HERA trial, where they have compared 1 year of maintenance trastuzumab versus 2 years, which showed that the DFS was in experimental arm was 69.3 versus the control arm was 62.5, and it was similar in case when even 2 years of trastuzumab was added. So there was no additional benefit, and it just lead to increased toxicity for adding 1 more year of trastuzumab. Pertuzumab is also a human IgG1 monoclonal antibody which binds to domain 2 of the HER2, blocks the ligand-dependent dimerization of HER2. So it is given as neoadjuvant dual HER2 blockade, like we saw if it is CT2 or node positive. And so we give around 14 cycles of trastuzumab, pertuzumab in stage 1 or stage 3. So it is selectively beneficial for patient with only node positive disease. It is even cardiotoxic, but it is considered less than that of trastuzumab. And also there is, next slide. So this is the affinity trial which compared combination of pertuzumab plus trastuzumab plus chemotherapy versus only trastuzumab plus chemotherapy. So that we saw in that we see in the node positive group, the disease-free survival was 90% in case of experimental versus 86% in case of. But however, the benefit was not much in case of node negative group. So it was almost comparable in case of node negative disease. So the conclusion about HER2-directed therapy is that 1 year of trastuzumab remains the standard in adjuvant therapy of HER2-positive early breast cancer. A dual HER2 blockade with pertuzumab may be considered in specific population, high-risk HER2-positive patient, that is mainly if it is multiple node positive. Shorter duration of trastuzumab may be considered in selected low-risk patients who can't tolerate for 12 months of therapy. And the anthracycline-based chemotherapy followed by taxane with concurrent trastuzumab or TCH that we practice here are the proposed regimens.
So what are the shorter duration ones, which you said, any trial which looked
Yes, sir,
at?
we will be seeing the next slide.
Okay.
Sorry, sir. Actually, I have added in my slide, but
Okay, that's all right. That's all right. There's a FINHER study, FINHER trial.
in her study, yes. So about
We
the
have only about 20 minutes remaining. So please, how many more slides you have? Because another thing also we have to cover. So please just show the relevant, most important studies.
okay. So this is about the anti-HER2, that is the trastuzumab amantacin. So this is a drug conjugate, and it is mainly indicated that we saw in the ESMO guideline that it is only indicated in residual invasive disease. Like after giving trastuzumab plus pertuzumab, if still after surgery there is residual invasive disease, then we need to consider for trastuzumab TDM1. So it is not indicated in without residual disease after neoadjuvant therapy or in stage 1 disease diagnosis. It is used as single agent and it has lower risk of toxicity. Next slide. So these are the two trials, the Catherine and the Kathleen trials, which have compared the trastuzumab plus TDM1 versus trastuzumab. So in HER2 positive, the disease-free survival was significant, was 88.3 versus 77. But in case of Kathleen trial, where they have instead of Avastin, they have added is a taxane. So in this, they have compared anthracycline plus trastuzumab TDM1 plus pertuzumab, while instead of Avastin, they have added is a docetaxel. So in this trial, there was no significant benefit of adding TDM1. Next slide. The tyrokinase inhibitors. So naratinib as a single agent after trastuzumab for early breast cancer, it is combined with aromatase inhibitor for HER2 positive disease, and it is found to reduce recurrence in ER positive, HER2 positive cancers. Next slide. So this is a study, EXINET study, which has compared naratinib versus the placebo. So what we could see here that the DFS rate was better in case of hormone positive, HER2 positive subgroup. Actually, it is typo. It was experimental. It was 12.3% versus in control it was 7.2%. However, in case of hormone negative, HER2 positive, the benefit was not seen much. Next slide. So about the PARP inhibitors. So normally when it is a DNA repair enzyme, and so when there is a double strand break, so in a normal cell there is a repair by the homologous recombination. But in case of BRCA mutated cell, there is no homologous recombination, and that's lead to cell death. Next slide, please. So the olaparib and the tirozoparib, which are used as single agents, and they induce high PCR rates, but they are not considered as a standard of care as neoadjuvant therapy. It is only reserved for adjuvant therapy in patients with residual disease. And the specific indication is in of germline BRCA1 or BRCA2 mutations, or if there is high residual disease after neoadjuvant chemotherapy. So the mainly duration is 1 year. Next slide. So this is a Olympia trial which is comparing the olaparib versus placebo, and it showed there is significant improvement in DFS in HER2 positive, hormone positive, HER2 positive subgroup, which was 83.5 versus 77.2. Next slide. About the CDK inhibitors. So normally the cell cycle progression for multiple growth factor or proliferative signal is regulated by cyclin dependent kinases C or 4. So the activation of this leads to degradation of the tumor suppression gene, which is a retinoblastoma gene. And this inhibitions activate RB and inhibits growth in both as well as estrogen sensitive and estro resistant models. Next slide. So the main drug we have is abemaciclib and palbociclib, and which is usually combined with the endocrine therapy. So this is considered in women with high risk stage 2 or stage 3 breast cancer, hormone positive, HER2 negative with either more than 4 lymph nodes, or if there are 1, 2, 3 positive lymph nodes with either T3 or the grade 3 histology, or the Ki67 is more than 20%. Next slide, please. So to summarize, about the CDK inhibitors, there is emerging evidence for adding CDK inhibitors to standard therapy, but it's for high risk hormone positive. So there are two trials, the PALAS and the Penelope trials, which added 1 to 2 years of palbociclib. But however, it did not show clinical benefit from the addition of palbociclib amongst patients. Similarly, there's one more trial, the Monarchy, which added 2 years of abemaciclib, and it showed absolute benefit in IDFS and disease-free survival. But however, there is no proven overall survival benefit yet. So at present, the CDKI inhibitor should be reserved for patients with high burden of disease, keeping in mind the side effect profile. So now we'll be talking about a hormonal therapy, which we discussed by Dr. Ramesh.
Sorry, after hormone therapy, what else was remaining?
So that's the only thing.
Okay, ठीक.
Am I audible, sir?
Yes, you are audible.
Hormonal therapy. Actually, it is an anti-hormone therapy. Why I will tell you. The 80% of breast cancers are hormone receptor positive cancer. That means that shows estrogen and progesterone receptors on their surface. These hormone therapy drugs acts via two ways, either decreasing the production of these hormones or blocking the binding to this their receptors. Not all breast cancers can benefit from this hormone therapy, but the cancers which are the breast cancer which is ER positive shows more good prognosis with this hormone therapy. We'll see the hormonal agents, which include selective estrogen receptor modulators, aromatase inhibitors, LHRH analogs, anti-estrogen, and progestin. Tamoxifen. Tamoxifen is a selective estrogen receptor modulator. The mechanism of action is competitive binding to estrogen receptor, resulting in reduced transcription of estrogen regulated genes. The benefit of this is delayed development of osteoporosis in postmenopausal women and favored lipid profile. The toxicities include vaginal discharge, hot flushes, thromboembolism, increased incidence of endometrial cancer by 2 to 3 folds, which is a late toxicity of this drug, hair loss, nausea, vomiting, atrophy of lining of the vagina, and menstrual irregularities. The dose of this drug is 20 milligram per oral every day. Now we'll see like for what duration we should give this hormonal therapy. There is a meta-analysis. There is a meta-analysis by Early Breast Cancer Trial Collaborative Group, 2011. They assessed total 20 trial, which includes assessment of 21,000 patients with early breast cancer, and total 10,600 patients were ER positive. There were two arms in the study. One is tamoxifen for 5 years versus no tamoxifen. The recurrence rate reduced by half in 5 years and by 1/3 in next 5 to 9 years. For overall time period, the recurrence rate reduced by 39%. There is a reduced breast cancer mortality by 1/3 throughout the first 15 years. The absolute mortality difference is 3% at 5 years and 9% at 15 years. The non-breast cancer mortality little affected despite small absolute increase in thromboembolism and uterine cancer mortality. So the all-cause mortality substantially reduced. There is no improvement in ER negative patients. Then there comes the Atlas trial, adjuvant tamoxifen longer against shorter duration. In the previous trial, we saw the patients were we saw the for 5 years rate. Now we'll see in this study, there were 12,800 patients with early breast cancers were assessed, out of which 53% patients were ER positive, 10% were ER negative, and 37% patient have untested hormone status. The study include the women who completed 5 years of adjuvant tamoxifen, out of which they were undergo the two arms. One which undergo tamoxifen, further tamoxifen for 5 years, completing total 10 years, and another arm, the patients were stopped tamoxifen. The recurrence rate was significantly lower among all these allocated to continue tamoxifen. The risk of recurrence during year 5 to 14 year was 21.4% who allocated to continue tamoxifen versus 25% in control patients. That is absolute recurrence reduction of 3.7%. And the breast cancer mortality in arm which allocated to continue tamoxifen shows 12.2% and versus 15% in control arm. That is absolute mortality reduction is of 2.8%. And there is another trial by Bartlett et al. Atom trial, adjuvant tamoxifen treatment offers more. The assessment here is 1991 to 2000.
You don't have to read each full slide. You can't describe 5 minutes for one study. All of you have to learn how to present slides in a short duration. You can't just go read by read every line. You should know how to make a slide. So what was this, in essence, tell us what was the ATOM trial? Randomization between?
So randomization in between the females who received 4 years of adjuvant tamoxifen, then they randomized into two arms which continue tamoxifen for further 5 years, and another arm is on observation. So recurrence.
So that to both these studies, you notice that there were many patients who had ER unknown because every patient did not have ER status. In the West, majority as such, 70 to 80% patients have ER positive disease. So when you say ER unknown, majority of them, 70 to 80% would be ER positive. That is one thing. Plus, they are randomizing if they have completed already 4 or 5 years. That means they had disease which was sensitive to endocrine therapy. Okay, that in itself has been like a selection for them. Okay, and both these studies showed that in long term it improved. Okay, conclusion.
So Atom and Atlas together provide there is a proof beyond reasonable doubt that continuing tamoxifen beyond 5 years shows reduced recurrences. And there is a reduction in the rate of recurrence and breast cancer mortality after 10 years.
Yeah.
The mechanism of action of aromatase.
That comes at a small excess toxicity for which you can monitor, especially the endometrial cancer. You can measure the endometrial thickness. Okay.
Now we see aromatase inhibitor. The aromatase inhibitor, the mechanism of action is inhibition of aromatase enzyme that converts androgen into estrogen, resulting in depletion of estrogen. In postmenopausal women, it lowers the estrogen production by 90% to nearly undetectable levels. AIs are not appropriate for premenopausal patient as there is a residual ovarian function can lead to increased production of aromatase and thus overcome the effect of aromatase inhibitors. There are two types of aromatase inhibitor. The type 1 is enzyme activators and type 2 is competitive antagonists, that is non-steroidal. Conditions are and the third generation includes anastrozole, letrozole, exemestane. The aromatase inhibitor can be given as primary or upfront therapy instead of tamoxifen, sequential therapy after two or 3 years of tamoxifen, or extended therapy after 5 years of tamoxifen. Side effects, aromatase inhibitors especially have an effect on bones, which causes fracture or musculoskeletal disorder. The lower incidence include vaginal bleeding, discharge, hot flashes, endometrial cancer, venous thromboembolic events, and deep vein thrombosis. Aromatase inhibitors versus selective estrogen receptor modulator. The 5 years of AI reduces 10-year breast cancer mortality by 40% as compared to tamoxifen. AIs are more effective than tamoxifen in preventing recurrence and breast cancer death. High risk of cancer is within the first few years of initial diagnosis. Hence, if AIs are to be used, they are used better to start with AI than tamoxifen.
So in the previous slide, just go back. You said, no, go back. No, next. You said 5 years of AI reduces 10-year breast cancer mortality by at least 40% compared to, you said tamoxifen or SERM. No, it is compared to no endocrine treatment. So they are slightly superior. Initial trial showed that they have better disease-free survival. There was no impact on overall survival. But later on, studies showed that yes, there is slight improvement in overall survival also. Okay, but only marginal. Okay, carry on. Next.
The endocrine therapy algorithm for premenopausal women, the low risk patient that includes T1, T2, low grade luminal AB, uh, will be given tamoxifen for 5 years or tamoxifen for 5 years plus luteinizing hormone releasing hormone agonist. The intermediate risk patient that is T1, T2, N1 positivity, more high grade HER2 positive residual disease post standard chemotherapy will receive tamoxifen for 10 years or tamoxifen for 10 years plus LHRHA for 5 years or tamoxifen for 5 years followed by aromatase inhibitors plus luteinizing hormone releasing hormone agonist for 5 years. High risk, which includes locally advanced breast cancer, invasive breast cancer, oligometastatic breast cancer, more than 4 lymph nodes positive, young age, residual disease post chemotherapy, will receive tamoxifen for 10 years or tamoxifen for 10 years plus LHRHA for 5 years or tamoxifen for 5 years followed by aromatase inhibitors plus LHRHA for 5 years. If HER2 is negative, we'll add CDK4, CDK6 inhibitors, that is ribociclib, abemaciclib. The endocrine therapy algorithm for postmenopausal women. The low risk patients will be treated with aromatase inhibitors directly for 5 years or tamoxifen for 2 to 3 years, followed by aromatase inhibitors for 2 to 3 years. Will complete total 5 years of treatment. The intermediate risk patients will be treated with aromatase inhibitors for 7 to 8 years or tamoxifen for 5 years, followed by 5 years of aromatase inhibitors or tamoxifen for 2 to 3 years, followed by aromatase inhibitors for 5 years. And the high risk patients will be treated with aromatase inhibitor for 7 to 8 years or 10 years as per tolerance. Tamoxifen for 5 years, followed by 5 years of aromatase inhibitors, or tamoxifen for 2 to 3 years, followed by aromatase inhibitors for 7 to 8 years. That is total 10 years. If HER2 negative, we'll add CDK4/6 inhibitors. To add bisphosphonate and calcium vitamin D supplements with aromatase inhibitors to prevent osteoporosis and to keep check on bone mineral densities for patients on AI. So adjuvant bisphosphonate therapy should be given to all AI aromatase inhibitor patients who are on AI therapy. There is a EBC TCG 2015 IPD trial which shows 2 to 5 years of bisphosphonate in postmenopausal women shows significant reduction in overall recurrence, distant recurrence and bone recurrence in breast cancer mortality. Hence, either bisphosphonate therapy or denosumab should be considered for some postmenopausal women on AI therapy. The summary of early breast cancer. As our patient, we started with discussion on this patient with a diagnosis of T2N0. We'll summarize the treatment. The breast tumor ratio, if suitable, ERPR, strong ERPR positive and low grade, will go for surgery first, then adjuvant chemotherapy as per stratification and adjuvant radiotherapy, and then maintenance endocrine therapy. If breast to tumor ratio is unsuitable, triple negative patient, HER2 positive, positive ERPR status, high grade, will go for neoadjuvant chemotherapy, then clinical radiological response assessment. And if patient is mammography suitable, motivated, compliant, will go for breast conservation. And the if the tumor is multi-cent, then go for mastectomy, then adjuvant radiotherapy, and then maintenance chemotherapy plus endocrine therapy. Recommendations for follow-up. Regular follow-up visits are recommended for every 3 months for first 3 years, then every 6 months for the next fourth and fifth year, and then annually after. Annually bilateral or contralateral mammography recommended plus breast MRI whenever needed. In asymptomatic patient, any lab test or any imaging not indicated. In asymptomatic patient with normal cardiac function who have received potentially cardiotoxic chemotherapy, cardiac follow-up should be carried out. For patients on tamoxifen, an annual gynecological examination is recommended. However, routine USG is not recommended. Reproductive and sexual consideration, premature menopause, infertility, potential sexual dysfunction should be discussed and addressed with patient when appropriate before starting any adjuvant.
Okay, so thank you. I think what is important is when you all are giving these teaching rounds, so don't make it like a typical seminar. There should be more practical point. You'll have to know how to condense the information. That is an art you learn. Okay, you practice how to bring out the relevant point there so that we could have more discussion on its practical applicability. Otherwise, just like a seminar or a big review article. Okay. So I think in future, when you all make the prepare the slides, please think about it that how much time you have, how many slides you can have. And each slide normally to explain properly takes about a minute, at least about a minute. So if you have total 60 minutes, how many slides you should have? Then there will be discussion. There are some practical points you want to say. You want question and answers. So you all please keep that in mind while you prepare your presentation. Okay. I think most of the information was there, but we could not discuss it so that we know what is important and what is not really important. So thank you very much.
Thank you, sir.